Namaste, Dr. Kiran here, founder of International Research Training Program. Welcome to our COE session, ongoing, continuing orthopedic education session. The topic for today's COE is L1 vertebral burst fracture management. Vertebral level of L1, there is a flexion and an axial compression of the L1 vertebrae. After a female of 18 years was hit from behind by a van, she jumped and she fell with a flexion attitude, and then she suffered more than 70% loss of vertebral height in the anterior aspect with the retropulsed blowout. It's a burst fracture into the spinal canal, and lucky for her, she didn't end up with any bowel bladder or deficits or weakness in the lower limbs. So there was edema in the cord. That's an indication that we should not delay. And then it takes 3-4 days time for the insurance approvals and other things. And there's optimum for time for a kyphoplasty also, 1 week. So my plan here is quite mathematical. And I would like to share how I strategized the approach for myself towards this young girl who was my patient. First thing, we are dealing with a burst fracture. We are dealing with a retropulsed fragment. We are also dealing with kyphoplasty. There are some precautions because the fracture lines will be multiple. There will be multiple. So if you are going to do a kyphoplasty, balloon kyphoplasty, elevate the end plates and then put cement. If there are multiple fracture lines, the cement can go through all these tunnels inside and come out anteriorly to the sides or even into the spinal canal. So, lot of attention. Even if you don't elevate more, no problem. But do not face the situation when you are out of control, when the cement leaks anteriorly or posteriorly, burning up the veins and the main aortic vessels or into the spinal canal, causing burns into the spine. So this was the situation, and now let's see. Anterior wedge compression fracture is usually stable, and sometimes it may become unstable, but burst fractures are unstable and they need treatment, surgical treatment. Now in this slide, what we see is an L1 vertebral burst fracture with loss of anterior and posterior height. Anterior height is lost more, depicting a flexion element in it, and also retropulsed fragment into the spinal canal. I hope you can realize, means it shows the anterior column and the middle column of Dennis involved. Dennis gave 3-column theory in the spine. Here 2 columns have been damaged, which classifies it as a unstable fracture. When the fracture of the vertebrae is unstable, the fixation must be well planned. So here we see the classification as a wedge compression fracture, burst fracture, chance fracture and other types of fractures. Here you can see the evidence of what I am saying. Burst fractures are unstable. So everything whatever we say must have a theoretical and academic backing. For the stability, when we come into the stability aspects, this slide amply tells us what and how we should assess the fracture in the lateral view, in the AP view. You can pause and check on each item. This slide is a depiction of how a pedicle screw goes through the pedicle entry point into the vertebrae. The very important aspect is it should not go to the tip because it may breach the anterior cortex, because the cortex is not a rectangle, it is an oval round, and when you are not triangulating it properly, it may protrude and cause some injury to the surrounding structures. Remember this. You have to be short of the edge of the vertebrae. Now that 2 pedicle screws have been passed into D12 and 2 into the L2 vertebrae, at L1, bilateral laminotomy was done and decompression was achieved. Laminectomy is avoided for the reason, even in a normal vertebrae, when there is a disc herniation of any degree, if you want to do a discectomy. Previously, laminectomy was done, but that destabilized posterior column. There was a removal of the posterior spinous process, interspinous ligaments, which destabilizes the posterior column. Here, the situation is we have lost the anterior column and the middle column. What is remaining is the posterior column, and that should never be removed, even though we are planning for a fixation. So, what I did was just a bilateral laminotomy, that is, just removal of small windows through which the spinal cord is approached and the spinal cord is retracted to one side. Here, in this case, right sided tilt compression was there in the burst fracture configuration. So, bilaterally, the spinal canal was decompressed. The retropulse fragments, which were already in a way moved anteriorly due to the posture of doing the surgery in a prone position, were further disimpacted, and then the next step was approached. We proceed to kyphoplasty procedure, where through the pedicles we are passing a cannula and then we are trying to drill to the sufficient length into the burst vertebrae. You may just penetrate into and enter the anterior aspect of the vertebrae into the soft tissues and abdomen, which will be a catastrophic rupture of the aorta sometimes. We should be very, very careful. Once we do that, next step is collection of the dye into the syringe, pressure syringe, and pushing it into the balloon. As it balloons out, inflates, it increases or elevates the end plates, as can be seen in the screen. It is done both sides. The injection of the cement is done very carefully, watching millimeter by millimeter retraction of the cannula and watching how the cement is going, where it is going. It's always best in certain situations to do less than more. It's better to underperform sometimes in these kind of cement, because as it sets in, it rises to extreme temperatures sometimes. Or if it forms a solid mass around any vital structure, that is the end of a very successful story. So please be careful what we are doing. There is no hurry. Be very careful. Watch under C-arm, AP and lateral. Now, what you have observed here is both pedicles have been used to elevate the end plates, and then cement has been pushed in gradually so that there is equal push up of the end plates. Do you understand, please? Equal push up of both the end plates is the approach that I chose. And finally, once the cement starts setting, we remove the pusher and then wait for the cement to set. One important aspect which I wanted to emphasize is, if you observe carefully the C-arm picture in the video, as I am pushing in the cement, I am also withdrawing the cannula out of the pedicle. Do you understand this point? This important step will prevent unnecessary cement clogging inside the tube. We have to withdraw it so that the cannula is empty by the time you remove it from the pedicle. And then we can allow it to set while we take out the cannulas from both the pedicles. What I did was, like I said, into D2 I had put 2 pedicle screws. Into L2 I had put 2 screws. Now these 2 screws, when I had distracted, the end plates of the upper end plate of L1, lower end plate of L1, because it has discal attachments to L1, L2, D12, L1, when they are separated, they pull up the fractured fragment on either side, restoring a little bit of its anatomical height. In addition to what we already gained while doing the balloon kyphoplasty. So patient was fine. The patient had originally come to me after the road traffic accident with this kind of a burst fracture at L1 with the loss of anterior and posterior vertebral heights, anterior column, posterior column failure, and a retropulsed fragment into the spinal canal. After I did the pedicle screw fixation into D12 and L2, and then after the kyphoplasty, when I did the ligamentotaxis, it has reduced greatly. Agreed that the restoration of the vertebral height is not so much, but safer than sorry is a better approach. All these things were done because surgeries are meant to be mathematical and to be implemented with zero error, which I think I achieved. Although the height was not fully restored because I didn't dare any cement leaking out. So it was 80% restored, 70-80%. I was happy with that, with a lesser cement than expected. But then it was complication free, and the patient, as you see now, post-operatively, she's absolutely fine, moving her legs, and God bless you, drive safely. 12 hours after surgery, spinal kyphoplasty with CD fixation. Patient is up. Please raise your leg, Nana. Right leg, right. Paiketinka. That's enough. Very good. Now we have to go and see some articles. Muller and et al. Others, they have studied on the ligamentotaxis aspect. I'm going to show you and share the citation from his article. What you must see in the lateral X-ray. What are the findings? What you must notice when there is a wedge compression fracture? How much is the loss of the anterior height? Then in the AP view of the spine, you must always check the interpedicular distance. You must also check the paraspinal line, which is normally seen, sometimes rarely it's not seen. You must notice the paraspinal line. If it is a little far away distant from the vertebral body, that means there's some kind of a bleeding or some other issue there, which is an abnormality there. So you can pay attention to that particular vertebrae. So with this, I sign off. Dr. Kiran here. God bless you. Namaste.